Welcome to our webinar on Chiari Malformation. I'm Dr. Stephen Fletcher. I'm a pediatric neurosurgeon here at Children's Memorial Hermann Hospital and an associate professor of pediatric neurosurgery at University of Texas Medical School, Houston. And today our topic is Chiari Malformation and Syringomyelia. And we have a PowerPoint presentation, and I'll go through these slides, and feel free to ask questions. I'll be able to see that as we go, and I may stop the presentation to answer a question, or we may just continue to go through the presentation and get to the very end. As many of you know, Chiari malformation is a particular entity. I hate to say disease, but it's an anatomic finding where the part of the brain called the cerebellar tonsil is actually below the level of the skull, as we have in this picture here. And syringomyelia is a collection of fluid, this white density that we see in the spinal cord that sometimes occurs in conjunction with Chiari malformations. So that's our topic today, and we'll try to cover the presentation of this entity, the history, and treatment for Chiari malformation, particular problems associated with that. We have, as part of a protocol, we like to disclose if we have any conflicts of interest, and to let you know, I have some grants with a couple of companies looking into a variety of things that we often use in Chiari malformation, and a grant from Christopher Reeve Foundation and from our neuroscience fund. I'd like to start out with a case that was kind of interesting of a 3-year-old boy who had vomited most of his life ever since birth. And although he gained weight, he had had multiple visits to the gastroenterologist and had an endoscopic procedures and x-rays to try and figure out why he was vomiting. Eventually, one of his doctors obtained a MRI scan that showed he had a Chiari malformation, and had some other tests that showed the electrical activity in the brainstem was abnormal. He underwent a surgery, and that corrected his vomiting. Sort of an unusual presentation for Chiari, but sort of a dramatic illustration of what we're going to talk about today, especially in regards to the compression of the brainstem and the variety of symptomatology that occurs with that. Another girl was a 6-year-old who complained of chronic neck pain and headache off and on for years. She had been treated with Tylenol and Advil, and due to the years of headache and some complaints of dizziness, one of her physicians ordered an MRI scan, and even though her neurologic exam was normal, we eventually operated on her, did a decompressive surgery of her brainstem, and she improved. So again, here's an example of the two studies I showed you at the first. This is a patient with a Chiari malformation with what we call tonsillar ectopia. The tonsils are down out of the skull, with resultant development of a large collection of fluid within the spinal cord. We call this Syringomyelia, and this is the Syrinx. This white stuff, this is the spinal cord. I'm sorry. This is the tonsillar ectopia. Here's the spinal cord. Here's the fluid collection within the spinal cord, all the white that you see. And this patient underwent a decompressive operation, and here we see the tonsils that are pretty much in the same location, and we see the spinal cord with much less fluid present. So historically, the Chiari malformation is not a new entity. Back in 1827, a physician coined the term Syringomyelia that was noted to be associated with some developmental abnormalities of the brain. And this doctor had discovered also the fluid within the cord. In 1803, Dr. Portal described a patient on autopsy who had noted to have numbness and paralysis in the arms and legs, but also at time of autopsy had a cavity within the spinal cord and associated problem with the brain where part of the cerebellum was below the level of the foramen magnum, or the lower part of the opening in the base of the skull. John Cleland was first really to describe what we call the hindbrain anomalies in a spina bifida patient, and then Chiari in 1891 described a variety of anomalies of the hindbrain that were associated with this entity, and he reported this in a medical journal with subsequent 24 more cases. Here is an example of Cleland's illustration, a drawing that he made in 1883. We will assume that this is the cerebellar tonsil coming way down below the brainstem. And here's Chiari's, Hans Chiari's description also with the cerebellar the tonsils below the level of the foramen magnum. This is just a picture of the brain after it was removed at the time of autopsy. So not only do we have the problem with the tonsillar herniation, but we have this issue of the syringomyelia. And a variety of mechanisms have been proposed at various times, especially before the MRI era, of the way that spinal fluid flows around the brainstem and what exactly causes this issue. If we look at this line drawing or schematic illustration of the brain, this is the pons, and this is the corpus callosum, and this is the third ventricle. And fluid comes out of the brain through the lateral ventricles into the third ventricle and down a small opening called the aqueduct and into another structure at the base of the brain called the fourth ventricle. Fluid eventually comes out of the fourth ventricle and circulates over the surface of the brain and also goes down into the spinal canal. You can imagine that if there's an obstruction right here at this area, and this is the cerebellar tonsil, this is the cerebellum, and if the cerebellar tonsil is distending, you can imagine that if the cerebellar tonsil is existing below the level of the foramen magnum, it puts a damper, so to speak, in the flow of the spinal fluid. But another alternative place fluid can go is out of the fourth ventricle down a small aperture in the brainstem called the obex and into the central canal of the spinal cord. So if all of a sudden we reestablish flow, and flow is blocked here and can't move freely, there's a potential that this flow can go down the central canal, and that may be one of the mechanisms of developing syringomyelia. It's a little bit more complex than that, and we'll talk about it in a second. Other proposed mechanisms also includes an outlet at the an obstruction where CSF comes out of the fourth ventricle at an anatomic structure we call the foramen of Magendie in the foramen Ilushka. And again, this blockage of flow here going down the cord, but another doctor in England, Dr. Bernie Williams, added also that there's probably a contribution from the epidural venous pulsations that exist around the spinal cord that creates also a pressure gradient where the fluid on the outside of the cord and the fluid on the inside of the cord are in disequilibrium, allowing for a buildup of fluid again within the cord, causing the syrinx. Much research is still going on at the current time to try and look at better way to prove these mechanisms and therefore come up with even a better way to prevent syringomyelia from getting worse. And Ball, Dillon, and Albuquerque all are researchers that have opined on this. One of the problems that exist in the patient with a syrinx is that if that fluid stays within the central canal long enough, gliotic changes or scar tissue actually can form around this cavity that may be part and parcel the reason that fluid remains even after decompressive surgery and may be a contributing factor to some of the symptomatic issues that occur in patients with syringomyelia. So why is this such a topic these days? One reason it's a topic is because MRI scans are readily available. In the old days, prior to MRI, about the only way people could be diagnosed with conditions of the brain and spine, especially surgical conditions, was to go undergo invasive studies. This is a picture of an old machine that used to be used called a pneumoencephalography chair. And this is a patient sitting in a chair, and a doctor would come in and do a spinal tap on the patient, drain some spinal fluid, and inject air. The air would go up into the head, and by looking at the distribution of air within the ventricular system, or if air never made it into the head, we often could surmise where a problem might exist. And in fact, many patients in the early days of neurosurgery had exploratory brain surgery based upon this primitive way of assessing where the problem might occur. Obviously, those patients that had severe problems were the ones that underwent these procedures. Somebody just had a headache, probably be real hesitant to have a pneumoencephalogram to investigate their headache. Fortunately, as CT and MRI came about, the need for this device went away, and patients now are fortunate to undergo pretty much a non-invasive test, that being the CT scan or MRI scan. So again, just historically, air ventriculogram. Here's a picture of a patient who had air within the ventricular system there and there. Fortunately, we don't have to do that anymore. When we have MRI scans, it allows to look at the ventricular system here, the brain itself, the fourth ventricle, and again, our topic today, tonsillar herniation down into the cervical spinal canal. So, a study done at in California estimated that the incidence of Chiari malformation could be as high as 1 in 1,000 patients. And in the old days, we used to say, well, it's only 10 cases per 10,000, 100 per 100,000. No matter one patient per 1,000 with some type of tonsillar ectopia or hindbrain herniation, that's a lot of Chiari patients. So half of our job is just trying to decide if there's anything to do with patients that have no symptoms. My colleague, Dr. Butler, who's head of pediatric neurology, we work very close together, and our concept here at UT and Children's Memorial Hermann Hospital is that a team approach to this entity is a great way to look at something. A non-surgeon, a surgeon looks at entities from a surgical perspective. A neurologist looks at various entities from a non-surgical perspective. So we often work quite well together in trying to figure out the best course of management for these often complex patients. So Chiari malformations, these patients often have headache, but also some of these patients present with mild hydrocephalus. They have headache, they may have hydrocephalus or mild hydrocephalus. Their Chiari malformation is often the focus because that's what somebody noted on an imaging study. These patients also have a propensity towards migraine headaches, and also a particular entity called pseudotumor cerebri, which is a sort of a misnomer, but this is a condition where the pressure inside of the brain is often elevated due to a problem with the absorption of spinal fluid. So you can see that it's important not to necessarily think everybody needs an operation. If someone has a strong history of migraine, family history of migraine, and migraine medications will take care of their headache, it might be totally unnecessary to do an operation for mild tonsillar ectopia. Often these patients have a variety of bizarre sensory abnormalities. This is just an anatomic distribution are pictures showing that some of the innervation or sensation of the face is due to cranial nerves, this being the trigeminal nerve. The trigeminal nerve has various distribution over the top of the head, over the maxilla or the midface, and over the mandible or jaw. And some of the cervical nerve roots supply sensation to the back of the head and over the upper cervical area around the clavicle or shoulder blade. And so it makes sense that if you have something compressing the brainstem or the upper cervical area, that you may have a variety of sensory abnormalities that can occur. Again, another example of putting the patient's complaints together with the anatomic picture and seeing if anything makes sense. If it does, it could be that a compressive phenomenon, such as the cerebellar tonsils putting pressure on the cervical spinal cord or the brainstem, may indeed play a role in these often bizarre complaints. Again, just sort of this is a little schematic diagram of brainstem and all the interconnections that occur that we use as physicians to try and help us figure out where the problem might be in these complex pathways, kind of like trying to figure out where the problem is in your computer. Is it in the software? Is it in some of the wiring issues, et cetera, et cetera? So Chiari malformations, the anatomy of certain clinical features. If the patient has hydrocephalus, they may present with a different clinical presentation than the patient that has primarily a cerebellar dysfunction, difficulty walking, an ataxia of gait, as we call it. They sort of staggering gait when they walk, or if they use their hands don't seem to be very well coordinated. You know, were they born like that, or did that develop slowly as their Chiari malformation and other things got worse? If they have direct pressure on the brainstem, sometimes that can present like I discussed in that first case. Vomiting, sometimes patients have snoring, respiratory issues at night. It's not unusual for us to obtain sleep studies on these patients. But a lot of these, this symptomatology is peculiar at an area of the brain that we call the cranial-cervical junction. In other words, where the head sits on top of the spine, so to speak. And in that particular area are the posterior columns of the spinal cord. This is a term that we give to that area of the spinal cord that carries sensation from the extremities up to the brain. The corticospinal tracts come together also, and the posterior columns are in the back part of the spinal cord in the brainstem. The corticospinal tracts, which have to do with motor movement, are in the front portion of the spinal cord or the brainstem. In those, this is particularly important in those patients who have a combination of a Chiari malformation and Syringomyelia, where the posterior columns, they may have gait abnormalities. Sometimes a patient describes it, I don't know where my feet are. They may have a variety of sensory aberrations, such as pain and temperature abnormalities. Sometimes if they've had long-standing compression of their brainstem, they may actually have muscle atrophy and spasticity. A variety of these patients may, in conjunction with all these above symptoms, may have bladder and bowel abnormalities or autonomic dysfunction. So when we see these patients as neurosurgeons or neurologists, it's not uncommon for the patient to come with their MRI scan in hand. We often will repeat an MRI scan if we don't think it's a good quality study. We often like to see a good picture of the brain and the entire brain. We like to see the cranial-cervical junction. There is a test called a CSF flow analysis. That's sort of a computer-generated study that lets us look at the movement and speed with which spinal fluid moves around the lower part of the brainstem and upper spinal cord. At our institution, we have been especially interested even back in the early 80s on evaluating the speed with which electricity moves up and down the brainstem and spinal cord. And there's a test called somatosensory evoked potentials where we put wires on the legs and arms and then on the head, and we can actually calculate the speed with which electricity moves up and down the cord and compare it to normals. And sometimes if the spinal cord has been compressed by especially long-term compression by tonsillar herniation, we'll see changes in the SSEPs. And the other test that we do, which is called brainstem auditory evoked potentials. This is yet another electrophysiologic test where we look at the electrical responses from a hearing test. We make noise in the ears, and we can put some electrodes on the brain and actually calculate how fast a noise gets from the ear to the brain and compare that again with normals. Often we'll do a spinal fluid analysis. It's very important if you think the patient's headaches are due not necessarily to the Chiari malformation, but to pressure inside the head from the entity I mentioned earlier, pseudotumor cerebri. Often a spinal tap will give us great information about the pressures that exist within the nervous system. Sometimes we'll complement our MRI scan with a CT scan to look at any bone changes or abnormalities of bone that may occur. We don't do this very often, but sometimes it's a complementary test. As I said, not everybody that has a Chiari malformation is a surgical candidate. And if you see a neurosurgeon and he's unimpressed with the studies, that's only part of the care of the patient. It's very important to come up with a team approach because if a patient comes to see me and they have headaches, and I don't think this is something that falls into the surgical realm, it's not uncommon to send these patients to our neurology colleagues and let them see what they can do for the headache. There are myriad causes for headache, and like I said, everything's not surgical. So our neurologists evaluate these patients for a migraine, family history of migraine. Sometimes we'll put the patient on a variety of medications to see if it works. You need to assess whether the patient has pseudotumor. It's important to do a good eye exam. Pseudotumor patients often have visual problems, and it's important to make sure they don't have a problem we call papilledema or changes in the retina that are associated with the long-standing pressure inside the head. Sometimes we'll see patients that need medication for their pseudotumor. A common drug that we often use is a drug called acetazolamide or Diamox. Some patients will see that with Chiari malformation that were operated elsewhere, or they were operated and did fairly well, and then all of a sudden they started having problems again. And it's important to make sure that they don't have a spinal fluid leak or a problem with their operation. Surgery often is not designed to take care of the Chiari malformation, but sometimes patients need a shunt or a diversion of their spinal fluid out of their brain to take care of their hydrocephalus. It's very important that good imaging be done, not only preoperatively if you're thinking about operating on the patient, but post-op. We like to do a post-op MRI scan at some point to make sure that we've accomplished what we wanted to do in the first place. It's important to educate patients that there's strong evidence that Chiari malformation and Syringomyelia may be genetically linked. So a history of talking not only to the patient but their family and other family members is very important in our initial assessment. What we don't know, we're starting to learn more and more about the natural history of Chiari malformation. My partner, Dr. Sandberg, recently published a study about the natural history of patients with Chiari malformation. They weren't really surgical candidates, and they were just followed for a while, and those patients actually did quite well. So again, a resounding theme you'll hear from me is everybody doesn't need an operation. Another thing we don't know is what is the best operation. If you put a bunch of neurosurgeons in a room and ask them what they think the best operation for a Chiari malformation is, you'll get a variety of opinions. Is it just to take the bone off? Is it to do a dura graft? We'll show that in a minute with some pictures. We don't know what the inheritance pattern is on these patients. We do know I've got quite a few patients that are twins, probably about 8 sets of twins, and if one of the patients has a Chiari malformation, it's likely that the other will have it. That's again why we need a team approach in looking at this data. We looked at 18 of our patients that had a Chiari malformation discovered as a consequence of a trauma that they had. And none of these patients had symptoms prior to their car wreck or bicycle wreck or whatever it was that would suggest that they had a Chiari complex or symptoms associated with a Chiari malformation. One child, however, and these patients were followed for quite some time, for years, and none of them wound up having an operation except one who was a youngster who played baseball, and he had a second injury, and that caused him some problems. He had to eventually have his Chiari decompressed. But the bottom line is that if you don't have symptomatology from this, and your MRI scan is not that bad, and that's where neurosurgical input is important, it's the better part of valor sometimes is just to follow these patients. What we do know is we do know that there's some patients with mild tonsillar herniation or ectopia that on subsequent MRI scans it goes away. And this oftentimes is we take into consideration the age of the patient, what their potential for further growth is, the fact that their skull is going to continue to grow, the fact that their spinal canal will get bigger, and often the brain actually floats back up into the skull. Tonsillar herniation can be associated with other entities that cause elevated intracranial pressure. Your cerebellar tonsils can be below the level of the foramen magnum in certain tumors, in an entity called craniosynostosis, where some of the bones of the skull are not opening up like they're supposed to be. Patients that undergo lumbar drains or drainage of fluid out of their back sometimes will develop a tonsillar ectopia or tonsillar herniation. Sometimes patients with shunts that we put a shunt in for hydrocephalus, if you put a shunt in that the pressure is too low, sometimes those patients can actually develop tonsillar ectopia, and a variety of other conditions that I've mentioned here. The clinical presentations of these patients vary tremendously, from headache to numbness in a foot to numbness in a hand that comes and goes to bladder and bowel complaints. And that's why it's important to try and sleuth these symptoms out, not only with a neurosurgeon and sometimes with a neurologist, because often it doesn't make sense. Somebody's got a very mild cerebellar tonsil herniation just slightly below the foramen magnum that have all these other kind of symptomatology. You just can't blame it on the Chiari malformation. These patients can have a variety of neurologic entities, and it's very important not to do operations on things that an operation is not going to help. In the past, it was felt that the odds of you having Syringomyelia and the Chiari malformation were somewhere around 50%. As we have moved into an era where more and more MRI scans are done, that association is much less. If hydrocephalus obscures a picture and you have a patient with a Chiari malformation but also with hydrocephalus, you got to really think hard that the hydrocephalus may be the main factor here, and you got to be careful about doing a Chiari decompression if hydrocephalus is the main thing that needs to be treated. The inheritance pattern I was talking about, we've had this 3 sets of twins now. I've got about 8 sets of twins with Chiari malformation, a set of quadruplets, and multiple patients with Chiari, it's discovered that the mother has the same entity. So the inheritance pattern, we haven't figured out exactly where that is, the genetics of that, but we'll probably get to that one of these days in the near future. Here's just a drawing to illustrate all the goodies, so to speak, that occur in this area. And so I talked about a variety of clinical conditions that are associated with this, but here's a picture of a line drawing of the brainstem, and here's the spinal cord here. Here's the cerebellum. This is the dura. This is the dura. I'm sorry, my pointer. I keep. Where is it? The dura is here. This is the spinal cord. These are the vessels around the brainstem and the cerebellar hemisphere. So you can see if we have something, a little bit of this cerebellum coming down below the level of the foramen magnum, which is right across here, you can see how you can have compression of the brainstem, compression of the spinal cord, and actually maybe some compression of blood vessels causing decreased blood flow to this area. So the pathophysiology of this problem may be due to a combination of, number one, direct compression of the brainstem and or cranial nerves, a constant or transient alterations of spinal fluid blood flow, maybe even repetitive trauma due positioning or motion. So I'll mention this, spend some time on this. We've had at least more than a few patients that have had an anesthetic procedure with a variety of positioning issues, and they may wake up with some neurologic dysfunction. And that may, if you can imagine this being a very tight area already, if you flex or extend the neck, and it causes any compression here, it may present a real problem. Traction on the brainstem from the tethered spinal cord. This is another associated condition that may be associated with Chiari malformation, and this is something that's more likely to occur in those patients that have a Chiari 2 malformation, which is associated with spina bifida, not necessarily the issue we're talking about today, the Chiari 1 malformation. So if it comes down to this investigation, which hopefully has been very thorough, that a surgical option is on the horizon, one of the things parents often come to us with is, what is the best surgery? And I guess the bottom line is the best surgery is that surgery that alleviates patient's symptoms and relieves pressure on the brainstem and improves CSF flow, and in a small group of patients prevents instability of the cranial-cervical junction, and provides a relief of that problem that's impeding CSF flow, and establishes better CSF flow and helps resolve the patient's syringomyelia if they have that. Therefore, the best operation, a survey of the American Association of Neurosurgery in 1998 revealed that most neurosurgeons felt that you had to do an adequate bone decompression, take some bone off the back of the neck called the lamina or the cervical lamina, and open the dura or the covering over the brain. However, there is evidence to show that sometimes all that is not necessary in select cases. So we presented at a meeting in the British Journal of Neurosurgery an abstract that showed that sometimes if we monitored the patient's evoked potentials in their auditory brainstem responses, that removing the bone alone resulted in an improvement of the waveform in their ABRs and in their somatosensory evoked potentials. And so in a few select patients, we just remove the bone. And in some patients, we've removed not only the bone, but also the dura. So I believe that the answer to what's the best operation is that operation that the surgeon's most comfortable with, that does exactly what I said previously, alleviates the problem. We like to monitor patients, see if there's any changes at the time of surgery, and we feel like monitoring sometimes will give us data that shows that we effectively change the physiologic milieu, so to speak, or the physiologic environment, and we may not need to do a more aggressive approach. So the Syrinx, or Syringomyelia. If you go online and you start looking up some stuff, the classic patient with a Syrinx was that patient that had what we called a cape-like distribution of anesthesia. These patients often had numbness and tingling, or numbness or anesthesia in their, or decreased sensation over their arms, over their shoulders, and over their upper chest. Interestingly, most of our colleagues think that we haven't seen very many people with this classic response. Often the symptomatology is due to is often an asymmetric sensory aberration, often associated anatomically with a syrinx that's a little bit different from one side to the other. So this cavity that occurs within the spinal canal isn't necessarily a nice symmetric cavity that's expanding the cord, and you'd think that the patient would be the same on exam from side to side. Again, the importance of this issue with the Syrinx is establishing enough room back here so that we can improve cerebrospinal flow here, because if you remember that one of those slides I showed you, the little opening, this area called the obex, this is where the fluid comes out of the fourth ventricle here and flows out this way. If something's compressing here, that other channel for fluid to move is down that central canal and down the spinal cord here. So it makes sense that giving the patient enough room here is the best option for letting that fluid come actually back out of the central canal, back up out of the obex, and in a better flow. So we have not we have a significant amount of experience with these patients. There's other groups that have even more than we have, but from 2003 to present, we've probably had around 1,300 to 1,400 patients with some type of problem that we would call the Chiari 1 malformation and or Syringomyelia, or a combination of the two. Between myself and my colleagues, we've probably done, actually this is old information, probably I would say it's probably closer to about 150 operations since 2003. With these patients having some type of craniotomy and or laminectomy, 3 patients having just management of their Syrinx with a procedure called a Syrinx to subarachnoid shunt. So again, this team approach is important to try and decipher not only the best treatment for these patients, but also a good follow-up for these patients after surgery. This is our primary complaint in 98 surgeries. Most of these patients headache, a headache variant, or some other type of problem with pain in the head. 3 with syncopal episodes or fainting, 5 with vomiting and a negative gastroenterology workup, 2 with pain in the chest and back pain, 1 patient just with arm pain and weakness, and 1 patient just with leg pain and weakness. And 5 patients presenting with interesting phenomena of walking on their tiptoes. So again, Chiari association with other conditions, hydrocephalus, migraine, pseudotumor, abnormalities at the cranial base. These include bony abnormalities of the way the skull's put together, previous trauma, craniosynostosis, and sometimes patients that have difficulties with skeletal growth. Some of the analogies, such as patients with achondroplasia or a variety of other conditions that affect the skull base. We feel like it's important not just to do an MRI, but often complementary studies really help us in decision making about the best way to proceed with the treatment of the patient. This can also include just plain x-rays of the cervical spine, a scoliosis survey to make sure that the abnormal curvatures of the spine are not present. Often an MRI of the entire spine is what we do before embarking on any surgery. Of course, as I mentioned previously, electrophysiology studies, including somatosensory evoked potentials and auditory brainstem responses. It's real important to see patients frequently, examine them, and take their history. If we think somebody's not a surgical candidate, we may change our mind 6 months later when you bring your child to us and say, you know, everything has been going okay, but now he's developed a little bit of numbness in his foot. Or we noticed maybe he's limping a little bit. What do you think? Well, what we think may be, let's repeat some of these studies or reassess things. Neurology and neurosurgery is a specialty that often involves changing our mind because the patient neurologic status may change, and we've got to be willing to reconsider surgical treatment even if we thought it wasn't necessary at first. Lumbar puncture, there's a big fear of patients when they hear the word spinal tap or lumbar puncture. This is often a very necessary test to make sure that the pressures inside the head are within acceptable limits. Every once in a while we'll have somebody that we just can't decide if they got pressure problems or not, and we'll resort to putting a little tube inside of their brain to monitor the pressure inside of their skull, inside their brain. CT of the skull, sometimes necessary to look at erosion, erosion of the bone and other anomalies of the bone, especially the way the skull sets on top of the spine. Currently, we are involved in some what we call volumetric studies. Some of my colleagues, neurosurgeon and radiologist, trying to figure out how the skull is put together, and is there a particular way the cerebellum and the skull are configured that would lend itself to determining actually what is the best surgery and whether surgery be successful. There's a renewed interest in endoscopic approaches to the skull base. Some of the neurosurgeons at the Cleveland Clinic have popularized this, and other places trying to do minimally invasive surgery. That's not part of our surgical approach, but it may certainly be something that offers an advantage in the future. Intraoperative ultrasound is a great adjunct to determining whether you've established CSF flow. Before we open the dura, once we get the bone off, we can get an ultrasound on top of the dura and look at CSF pulsations, and then after we've finished our procedure, reassess the ultrasound and make sure CSF is pulsating adequately. Again, monitoring SSCPs and ABRs. Oftentimes we'll see changes for the positive. We'll see improvement of the, especially the ABRs after decompression, further lending credence to the fact that our surgery has accomplished what we want to do. The reason this is important is because sometimes there's a mindset in the surgeon, with the surgeon, that we got to take even more bone off and we got to do a bigger operation. Sometimes a small operation with less bone removal is adequate. There are complications to taking too much bone at the base of the skull, so we want to try to do what's needed, but we don't want to do something that's going to get us into trouble. What are the complications of surgery? All surgery, no matter where it is in the body, has possible complications, and one is a spinal fluid leak. Sometimes patients react to the materials the materials that we use in surgery, and this is called aseptic meningitis or chemical meningitis. Sometimes if we take too much bone off the spine, or there's abnormalities like I said with the way the skull sits on the spine, that can lend itself to instability of the spine years later. We don't want to think about having abnormalities with blood vessels, but there are a lot of blood vessels, like I showed you a while ago on that illustration, and damage to one of those could potentially result in a stroke. Arachnoiditis is a particular complication that involves scarring of the meninges around the area of the surgery. Pseudomeningocele is a spinal fluid leak that can occur at the operative site with a buildup of fluid around the operative site that often requires going back in and finding the leak and repairing it. Often patients, we can usually bet that if we decompress our Chiari malformation, their Syrinx will get better on subsequent imaging. Sometimes it takes a while for this, and Edward Oldfield at the National Institute of Health, Ed's now at Virginia, showed that if you just wait and be patient, that Syrinx will resolve if you've done an adequate Chiari decompression. So many surgeons were often disappointed that the Syrinx didn't resolve, and sometimes felt like a repeat operation was necessary. And I think the data would show that just a watchful expectancy, subsequent MRIs will take care of the Syrinx problem. So this, there's a lot that needs to be done. This is more than just doing a good operation. We still need to look at, if we're not going to operate on what is a natural history of these patients. They probably need to be followed out for many years with subsequent MRIs. What's the best operative procedure? If a neurosurgeon has good luck and good results with the particular operation he does, it's probably going to be real tough for somebody else to argue with him that he needs to change his operation. This is a real issue, chronic pain management. Patients with Syringomyelia, these patients often have a long-standing history of chronic pain. Good pain programs are necessary to deal with these patients. These patients have significant problems that have to be addressed, and trying to figure out exactly what is the pathophysiology and natural history of Syringomyelia. So again, our group is looking at volumetric studies, trying to figure out, is there a configuration of the MRI scan? If you could just look at the MRI and say, hey, this is the best operation to do on this patient, that'd sure be nice. Does minimally invasive surgery have an advantage over bigger operations? Can we spare the lamina? We're currently working on a select group of patients where we actually try not to take the lamina off, but just reconfigure the lamina, especially C1 and C2, and modify it where the bone is still present. There's a certain group of patients that need bigger operations. They need to have a lot of bone removed from their spine, and they need to have their skull fused to their spine. These are patients that have what we call retroflexed odontoid. The second cervical vertebra actually is abnormal and pokes back into the brainstem, and just doing an operation posteriorly, removing bone and back, isn't necessarily adequate. As we move into better and better genetic studies and look at these patients, enrolling them in genetic studies is especially important to try and figure out, can we prevent this with genetic modification? Molecular biology, the bones of the skull. It's well known now that the occipital bone is a different bone than some of the other bone. And Syringomyelia. There's deformational studies or studies being done with models to look at what causes the syrinx in the first place. There's another type of syrinx called hematomyelia that occurs with spinal cord injury patients. There's a lot to be done to try and figure out how to prevent that in those patients that have injured their spinal cord, keep their syrinx from getting worse. What is the natural outcome of these patients with or without surgery? It's important, if we're trying to figure out the best operation, it's really important to have that verified that 10 years down the line, that best operation actually is the best operation, and compare it to other kinds of operations. That's what an outcome study is. What's the best outcome associated with this particular type of operation? And association of Chiari with other entities, such as craniosynostosis and elevated intracranial pressure. So here's a few references that you can, for future reading. We'll get to some questions now. First question, do we know if it is hereditary? And if your child has scoliosis at an early age, at age 6, with headache, should we have the patient assessed for Chiari malformation? Absolutely, the scoliosis issue needs to be looked at. As our orthopedic colleagues that do scoliosis surgery will tell you, first investigation for the patient with scoliosis is, especially that patient who's got progressive scoliosis, is to look for associated issues on a neurologic basis. Is it hereditary? I think the evidence would say that it is hereditary. We just need to find where that genetic problem is. Next question, my son with Chiari malformation at age 2.5, due to temporary losing ability to walk, has severe vomiting. He was decompressed at age 3. At the time, no hydrocephalus and no syrinx. He is now age 14 and has done great. Recently, he experienced back pain and will have an MRI. We'll have an MRI. How does scroll down? We'll have an MRI soon. Is it reasonable to be concerned that the symptoms of his back pain could be due to a syrinx? I think it's reasonable to worry slightly about that, but if he did quite well after his surgery, hopefully his back pain will be generic back pain and nothing else, and not related to a syrinx. It is good that he's having an astute doctor just check up on a MRI scan on him. Next question. My 2-year-old son has spina bifida and a meningomyelocele. He has a Chiari 2 malformation in the syrinx. His spine has started to curve, and he has started having headaches. One neurosurgeon wants to do another decompression, and the other does not. His syrinx is very large, and it goes throughout the spine. So the answer to that is the spina bifida patient needs a thorough reassessment. I don't know if the patient has a shunt or not, but if he has a shunt, certainly needs to have an assessment of the shunt and whether it's working or not. That's primary issue number one. If the shunt is working, then the next issue would be how bad is the tethered cord from the meningomyelocele repair, and this sequence of workup is usually pretty standard. But it is important to make sure that hydrocephalus is not part of the issue. The curvature is a symptom of this, and it needs to be a progressive curve, however. Just a good scoliosis follow-up is certainly necessary. Is there a minimum age for a child to have decompressive surgery? Was the youngest person that you've heard of that had decompressive surgery? Well, the child I discussed at the very first, who vomited every day of his life, I think I operated on him at age 2.5 years. I don't think there's a minimum age or anything else. I think, again, this depends on, number one, symptomatology, and number two, the realization that things change with growth, and you got to be cognizant of that fact. My son, age 20, has a Chiari 2 and Syrinx through the thoracic spine. He's shunted, hydrocephalus, having sensory issues in the arms and hands, no weakness. Is it okay to wait to have no change in MRI for many years? Is it okay to wait to have surgery? Could a malfunctioning shunt cause these symptoms? Again, shunt workup is extremely necessary to make sure a shunt's okay. I'm not sure what other surgery would be necessary until the Syrinx is, until the shunt is deemed functioning. If the shunt's deemed functioning, then yes, decompressive surgery at the cranial base may be necessary for management of the Syrinx and/or release of a tethered cord. My son had surgery in 2008 and developed several complications directly after surgery, one being meningitis, two being hydrocephalus. Wait a few good years, now the symptoms have returned. What are the chances of it being the Chiari has returned? I think the issue there is post-meningitis complications. There's certainly a chance of scar tissue that could have formed. This requires a thorough workup, including an MRI with and without contrast. I think not so much the issue of the Chiari returning, but maybe complications of scar tissue around the repair and almost a tethering of the area of the Chiari surgery. Of the 98 patient study, how many saw vast improvement of their symptoms? Most patients with this operation, if they're done for the right reasons, do get better. I mean, there can be some lingering complaints, and that's why it's good to have a team of physicians. If you operate on somebody that's got a bad Chiari malformation and they're continuing to have headaches, that's where a good neurologist comes into play. And if they start developing vague neurologic conditions, a reassessment not only by a neurosurgeon but also by another member of the team. My youngest child shows symptoms of Chiari, yet on an MRI it didn't show up as a Chiari. So what should I do for her? That's where you need a neurologist to sleuth this out. Should a PCP picked up a Chiari malformation? I mean, it's hard to say. I mean, the diagnosis of a patient's conditions is often based on their history and exam. As we move into an era where it's easier to obtain a MRI scan, it's certainly when the signs and symptoms suggest that, that's probably going to be the diagnostic procedure of choice. I had surgery in 98 for Chiari malformation. They found a cyst a few years ago. Now my symptoms have returned with daily headaches and numbness as well as choking. I'm not sure what you mean by a cyst other than unless that's a pseudomeningocele. If that's something that has occurred, then that probably needs to be addressed as to whether it's compressing anything. My mother had numbness in her arms and severe pain. They told her she has a hairline fracture. However, what are the chances of it being a Chiari? I'm not sure a hairline fracture of what area, but most of the time I wouldn't think a fracture at the skull base would be unusual, especially in an older patient. An MRI scan be the best procedure to check on that. There are 5 people in my family with Chiari. I have 2 girls and 1 boy. My son has it as well. What are the chances of my girls having it? This is a strong family history. the odds are probably pretty good that someone else may have it. However, the issue is, do they really need an imaging study? And I would say probably not unless they're symptomatic. Can I still talk? So that concludes the webinar. A couple of educational sites that I found particularly useful for patients is a group called out of Chicago, Conquer Chiari. This is their website. Great group in the American Syringomyelia Alliance Project out of Longview, Texas. This is great reading for those of you that like to expand your knowledge of this particular entity. Anyway, I thank you for your time. I believe you can still send emails in. One last question was: is it possible to have a large Syrinx and not a Chiari? The issue is yes, spontaneous, an idiopathic Syrinx can exist without a Chiari. This is something that really needs thorough investigation. And you're welcome for those for the thanks. And just you can contact us if you need to for further emails.